Hi, my name is Dr. George Lachenko, and I will be talking about prostate artery embolization for patients with BPH who are having urinary tract symptoms. BPH, or benign prostatic hyperplasia, is the overgrowth of the stromal cells of the prostate, causing enlargement of the prostate. And some of these patients, or most of these patients, eventually will get bladder outlet obstruction, which will cause their lower urinary tract symptoms such as nocturia, frequency, urgency. Treatment options for mild BPH that do cause symptoms are medications such as Flomax. Treatment options for patients with severe BPH symptoms include certain transurethral therapies such as transurethral resection of the prostate, or better known as TURP. There are some newer treatments such as holmium laser enucleation, green light laser, aquablation, urolift. Minimally invasive procedure that I perform, that my other partners perform in our group, is prostate artery embolization. So the difference between prostate artery embolization and the other therapies that I just discussed are the decreased complications. So with, for example, transurethral resection of prostate, 80% of patients will get retrograde ejaculation. You also have issues with erectile dysfunction. Can be significant bleeding after the procedure, and the recovery is also much longer than prostate artery embolization. Prostate artery embolization, in comparison to going into the urethra to take out prostate tissue, utilizes the blood supply to the prostate to decrease the prostate blood supply in order for the prostate tissue to necrose and the body to absorb the tissue without needing to do any surgical interventions through the urethra. So the PAE procedure, in brief summary, is about two hours long on average. Can be shorter, can be longer with more patients more difficult anatomy. It's an outpatient procedure. Patients usually come in an hour before the procedure. We get them ready by placing an IV in order for us to be able to give them sedation. The procedure isn't painful in itself, besides some numbing medicine over the wrist or groin where I get access to the arterial system. It's just that it can be on the longer side, and it's very important for the patients to stay still. So that's why we give them a little bit moderate sedation, or as some people call it, twilight. Then I advance a catheter and wire into the prostate artery on each side of the prostate. Usually there's one on each side. The anatomy is very variable, so I can do a CAT scan angiogram on the table while doing the procedure to be able to delineate the prostate artery anatomy, because what we don't want to happen is any of the material that we put into the prostate arteries to block the prostate arteries, we don't want those to go into other vessels that, say, supply the rectum, the bladder, or the penis, which is called non-target embolization. So imaging is very important, and is very important for the patient to stay still during the procedure to get great imaging in order to have a good result and a safe result without any complications. The expectation of symptom resolution or symptom improvement is a little bit longer than for any of the transurethral therapies that I mentioned earlier. We wait for the body to absorb the necrotic tissue of the prostate, which can take a couple weeks to start, and then usually the peak improvement is about 3 months. Some patients do continue to improve past 3 months, but most of the time I tell patients that 3 months is when you get that peak improvement, and I will see the patient back around that time. A typical PAE patient is one that has extensive nocturia, meaning they get up in the middle of the night at least 3 or 4 times. They're going to the bathroom very often. Some patients, every couple of hours. Weak stream. They're not able to get all their urine out. Having to start and stop. So just significant issues with being able to urinate. And they also must have a prostate that's enlarged. So typically, on average, the prostate size that I see is around 80 grams, but I've performed this procedure on patients anywhere from 50 gram prostate to 280 grams was probably my biggest one. But the average patient is one that has moderate to severe symptoms, and an enlarged prostate around 80 to 100 grams. In my experience, 90% of patients have excellent improvement in their symptoms. So the literature says that a successful PAE is one where the patient gets about 50% reduction in the IPSS score. What I find in the technique I use, which is the perfecta technique, that patients get more than 50% improvement. So I get about 70-75% improvement of my patient's symptoms